Hello, thanks for joining us today. My name is Zoe Etter, and on behalf of MEGIN, I'd like to welcome you all to this MEGIN Masterclass with our guest speaker, Dr. Willem de Haan. Please use the Q&A button on your screen to send in questions at any time during the masterclass. There'll be time for Dr. de Haan to answer your questions at the end of the session. This webinar will also be available to watch on demand on the MEGIN website at a later date. So without further ado, it gives me great pleasure to hand over to Dr. Willem de Haan, who will officially start the webinar. Thank you.
So good morning or good afternoon, everyone, and thank you, Zoe, for the introduction. Of course, I'm very happy to talk to you today about our work at the Amsterdam UMC Academic Hospital. And I think I have a bit of a mixed talk focusing, of course, on MEG, but also on EEG and the research we have been doing with a special attention for applying this EEG and MEG for clinical trials. So I think I have a quite diverse talk, and there will be a room at the end definitely for a question. So hopefully I will be able to answer them if they are there. And let me if all's well, you can see the title screen. So I work as a neurologist at the Alzheimer Center of the Amsterdam UMC Hospital. I've done my neurology residency there, and also my PhD, which was in neurophysiology on brain networks in dementia. So in my talk, I will focus a lot on dementia and specifically on Alzheimer's disease, and to give you a bit of an overview of what I would like to talk about. First I should say that my disclosures, with our EEG lab, we do participate in clinical trials by different sponsors, but I don't personally receive any funding from them, as I'm fully employed by the Amsterdam UMC. And I have some personal scientific grants for research that's focusing on brain stimulation. And that will be, I will talk a little bit about it in the end of my talk, because we also connect brain stimulation with MEG actually. So to give you a bit of an overview of what I would like to talk about, I would like to give you a bit of a background where we're coming from. So I talk a little bit about our center here and about the research we have been doing on EEG and MEG, and then move to the more larger part, which will be focusing on the EEG lab, as we call it, where we provide advice and analysis for clinical trials, what we've done so far, what we've learned from that, and then in the end, I would like to talk a little bit also about, I think, quite exciting new developments that are we have been working on for a while, and that you also see happening in the field. And these are also developments where I think that MEG could play maybe even a larger role than it's playing at the moment in neurophysiology of dementia. Okay, so the Alzheimer Center in Amsterdam has now been there for approximately 20 years. During the time when I did my PhD, starting in 2008, it was still a small group with about 10-15 people, but has grown exponentially, and at the moment we are 150 plus employees. So that's a large bulk of them is researchers, but also physicians and other personnel. And we are based in the Amsterdam UMC Hospital in the south part of Amsterdam. And we focus on cognitive neurology. So we see a lot of people with cognitive disorders, mainly focusing on forms of dementia, but also other neighboring conditions with cognitive disorders are seen by us. This is a slide with just some statistics from, it's not completely up to date, this is from a few years ago, but just to give you an idea of what kind of patients we often encounter when you look at dementia in our center. And then on the top left, you see a bar diagram of the types of dementia that we see. So of course, I'm not completely sure how familiar you are with the topic dementia or with the different forms of dementia. So Alzheimer's disease, or AD, is a prevalent disease in our clinic, but also other forms of dementia like FTD, or frontotemporal dementia, and DLB, Lewy body dementia, and VAD, or vascular dementia. Those are also like the top 4 most common causes for dementia. And then we have other large groups, as you can see here, with the abbreviations SCD and MCI, which are the people with subjective complaints and mild cognitive impairment. So they do report with cognitive complaints, and then after testing, we may not find any specific abnormalities, and then people are in the SCD group, or we find mild disturbances, not at a dementia level, but at a mild cognitive impairment level. And yeah, these make up the main categories of the people that we see. And when people come to our clinic, now as you can see now, this cohort, what we call the Amsterdam dementia cohort, has been growing over the years. Now we're approaching about 8,000 participants there. A lot of these people are also followed up clinically when they are treated, but also when they are in, for example, in the MCI stage, where there is a higher risk to progress towards a dementia, but which could still also be due to a different cause. This is a group that we follow up quite intensively, because we want to see if they actually progress to dementia, and then we can also act on that and arrange care and sometimes treatment, or maybe address other causes of the cognitive impairment. And yeah, what we believe in is that we have a quite strong integration of clinical care and research. So when people come to our center, and people come to our center straight from the general practitioner, or also from other hospitals in the Netherlands. We're one of, well, 3-4 larger dementia referral centers. So we often see a lot of second opinions as well, people coming from other neurology clinics. Yeah, we usually have an approach where when people come and on the first day, they will have most of their examinations. So they will, of course, speak with a doctor, but they will also have a neurological examination, neuropsychological examination, and there usually are also additional tests being performed at the same day. So that can be imaging. There will be EEG or MEG. I will get back to that later, of course, and a consultation with our care consultant. And that's quite intensive. It can be quite tiring for patients, but the big advantage is that then in short, within 1 or 2 weeks, we have a very extensive examination, and usually much certainty about the underlying diagnosis. And we also couple that to participation in scientific trials. Of course, this is up to the patient to decide if they want to participate, but we do look for them what is available, what they could participate in, and then discuss this with them. And a large, I would say, a majority of our patients actually involved in some kind of research project. So that can be can be a medication trial, but can also be something completely different, like questionnaires about the home setting, or digitalized neuropsychological tests. Can be different topics. And one of them, the new ones, is also brain stimulation research, as I will say a few things about at the end. So the Amsterdam dementia cohort, because we do quite a lot of diagnostic research, these people are well characterized, and therefore, yeah, the database that we have is quite rich, and can be used for all different types of research. So we have different research branches here, like imaging. So there's a lot of MRI and PET research, but also blood and CSF biomarker research, genetic research, but also neurophysiological research. So moving a bit more to neurophysiology, what have we been doing? So we have been using EEG and MEG now for approximately 20 years in our clinic. And we realized this is not the case in most of the memory or dementia clinics. It's not, the EEG and MEG are not standard diagnostic tests to use. They appear in the guidelines a little bit, but most hospitals don't really involve EEG or MEG in their diagnostic routine. Of course, we think this is a pity, because I think in our experience, we see the advantages of using EEG and MEG. I'll say a bit more about that shortly. But maybe it's good also to zoom out a little bit and to think about why we are actually interested in looking at brain activity and brain function in dementia. If you look at these pictures, and when you look at the dementia research field, I think a lot of the research is focused on the pathology, which of course is very rightfully so and very understandable. So the main hallmarks of, for example, Alzheimer's disease are the protein depositions in the brain, like amyloid deposition, tau, and we now have the atrophy that you can see on, so the loss of brain cells that you can see on an MRI, for example. And we have better and better techniques to show protein deposition in living patients. So, for example, with PET imaging or with CSF examination, you can show abnormal amyloid levels, for example, and tau, which can greatly help in diagnosing specific Alzheimer pathology. On the other hand, we know a lot about the symptoms in dementia and in Alzheimer's disease. So the classical picture for Alzheimer's disease, of course, is the gradual memory problem, then gradually spreading over to other cognitive domains. So loss in executive function, so kind of dealing with daily tasks, language problems, visual spatial problems. Nowadays, we also know that there is not one disease, but it seems to be like a collection of different variants, because we also, and this is something we see especially in the relatively younger people with Alzheimer's disease. As a center, we focus a bit more on the relatively young people. With young, we usually mean below 65. And there you see that, instead of the classical picture of starting with memory problems, you also have people where the disease starts with language problems or visual spatial problems. So people have trouble recognizing familiar objects or even familiar faces. Completely different start of the disease. And you can also imagine that those people come to our clinic with quite some delay, because at first people think, oh, this might be an eye problem, sometimes it can also start with behavioral complaints, and then people then think, oh, this might be due to a psychiatric problem, or for example, depression or burnout. So just to illustrate a little bit how diverse dementia and Alzheimer's disease can be. But what I wanted to point out here is that although we know a lot about pathology and about the symptoms, we still do not really understand the full picture. So what the connection between the pathology in the brain and the symptoms is still difficult, because we know that there are people who have quite a lot of pathology in their brain, but only mild symptoms. We also know people that have the other way around, so only mild pathology, but already severe cognitive problems. So there is some kind of mismatch between this damage to the brain and the severity of the cognitive impairment. And of course, as neurophysiologists, we like to point out that what is missing in this picture, of course, is what happens, what you could say in between, is that how does the brain, which is of course an extremely dynamic organ, and you could say that the core function is information processing, so it's very active all the time. How does it deal with the damage that is occurring? How does it change its activity? How does it adapt to damage? I think you can say that it's hard to fully understand the disease mechanism of dementia if you don't understand how brain activity and function is changing due to the pathology. So of course we think it's important for different purposes to focus on understanding activity, not just to understand the disease mechanism, but of course also for more applied purposes like improving diagnosis, improving prognosis, so what to expect in the coming years, and maybe also improving treatment. A little bit more in detail, again, about Alzheimer's disease. So what happens, and here we zoom in on the cellular scale. So we look at a few neurons, and what I already talked about is this amyloid deposition that happens. We don't know exactly yet why this happens. There are a lot of factors involved. There's some genetic factors that might be involved, but there's also other processes going on at the same time, problems with immunological processes, with lipid metabolism, other types of metabolism, dysfunction of different cell types. So it's quite a complicated story, but here I stick to the main culprit, or the amyloid, which ends up in the synapses, where it actually blocks the normal synaptical function in different ways. And if you zoom out a little bit and you go to a larger neuronal network, of course, these neurons, they have to be connected and they have to communicate with each other, and they do so through the many synapses that they have. But you can imagine that if synaptical function deteriorates, then these neurons, they lose touch and they lose their communication. And then if you zoom out even further, what you will end up is with brain regions that are not able to communicate efficiently anymore. Before there's actually an extensive loss of brain cells and of connectivity, you can see that the neurons start to behave differently. And it's not, you could expect, oh, they lose connectivity, so maybe it's just the cognitive impairment is due to the loss of brain cells. But we strongly believe that the impairment is also due to the different activity or the different behavior of those neurons. What you, for example, see in an early stage, that there is hyperactivity in neurons, which is not a good thing, because neurons, to communicate, they need to be able to synchronize their activity with other neurons and with other neuronal circuits, a bit like radio transmitter and receiver being able to communicate on the same wavelengths. Well, a bit like that, it's the same with neurons communicating. So a neuron firing faster or firing harder is usually not a good sign. And what we seem to see is that amyloid, so the Alzheimer protein, seems to be excitotoxic. So it seems to drive neurons toward a hyper-excitable, hyper-active state, which is not beneficial. And if this is chronic, then these cells cannot keep up with the high metabolic demands coupled to this hyperactivity, and then they are presumed to die. So of course, yeah, probably most of you will be familiar with this. With EEG and MEG, we are able to measure activity of large groups of neurons and large number of synapses from the outside in a patient-friendly way. So we are able to look at the combined electromagnetic field from, well, you could say millions of mainly cortical neurons, and it's kind of a summation of their electromagnetic fields. And with MEG compared to EEG, of course, you have higher precision, so you have a higher spatial precision. You can zoom in on smaller regions, and you're also better able to focus on deeper structures, and you have less interference from the tissue in between, like the skull and other tissue that is there. So in that sense, MEG, of course, has a clear technical advantage over EEG, but also with EEG, we can make, well, there's by now quite a large body of literature that shows that also in dementia, you can pick up very useful signals and use that for diagnosis. So to say a little bit more about what kind of analysis you can do, and I think that is quite similar for EEG and MEG. Traditional, of course, you have the visual analysis, so we just look at the recording of the screen. This is mainly for EEG the case, because there you have usually about 20 channels. And experienced clinical neurophysiologists, they can, by visually looking at the signals, like you see here in the center of the screen, and they go through a whole examination, they can, they can make a judgment about whether the brain activity coming from different regions looks normal, or when there's actually abnormal types of activity for different conditions, of course. With MEG, it becomes more difficult because you have so many channels, usually a few hundred, like our current system has about 300 channels. So the amount of information on your computer screen becomes so large that it's quite difficult to judge this visually. But fortunately, we have nowadays very good software that helps us in calculating markers from this information, from this data. And here on the screen, you see a few examples of the types of visualization or quantization you can do. So you can look at what kind of frequencies are in these signals. Do we see mainly slow activity or fast activity? You can map this to the brain, like you see in the left lower corner, different frequency ranges. So you are informed, like in what part of the brain do we see certain frequencies, and then we can relate this to what we know about healthy brains and brains in a disease condition. So we can say, okay, this looks normal or looks abnormal. And then even a bit more advanced, and this for now mainly I think for research purposes, but we can also look at communication between brain regions. So from these signals we can calculate what we call functional connectivity. So we can see, which different brain regions are communicating, and how strong is their communication. And when you can do that, you can also build a full communication network, where you see some examples on the right here. This is of course not like actual anatomical realistic, but this is more like a schematic overview. So the idea is that you can look at the interaction between regions, which is of course very relevant if you want to study cognition, because in cognition we know that it does depend on specific brain regions, but it also definitely depends on the interaction between different brain regions. So this communication is very important, and with these measures, looking at connectivity, we can also see that communication, if it starts to change, if it decreases gradually over time, or if there are certain regions where there's higher connectivity, for example. So now there are a lot of techniques, advanced analysis techniques that can be applied to the data. And that's also where we as a center are active in. We try to develop new measures and new markers that might even give more more robust information about what is changing in the brain in different conditions. So I could say a lot about what we see in Alzheimer's disease. This is a very brief summary, and I think this shows I think the most important results. But I do realize that we have a specific focus here, because we focus mainly on resting state activity. So of course you can also do let people perform cognitive tasks while they are in the EEG or MEG scanner, or you can do evoked potential. So there are different ways of. That's not data that I will discuss today, so I'll focus on resting state data. So that's just the spontaneously occurring data when you just ask people to sit in the scanner awake but with their eyes closed, mainly eyes closed. Then what do we see in Alzheimer's disease over time? Well, we see a gradual slowing of the typical brain rhythms that you find in healthy adults. For example, we have this posterior dominant rhythm, which is a brain rhythm which is around 10 hertz in the back of the brain. This is something you see slow down in Alzheimer's disease. So gradually you go towards 8, towards 9, towards 8. If it becomes below 8 hertz, then we definitely consider that to be pathological. There is some individual variability in this rhythm, but if you see this slowing over time, and there is some slowing over time with aging as well. But yeah, this is one of the most robust changes that we see in Alzheimer's disease, that there's a stronger slowing of brain activity. Yeah, the slowing, you can express the slowing with different specific markers, and I will mention a few of them later on. Another thing, and I talked about it a bit already, is this loss of communication. So there are markers that can describe how strongly regions are communicating, and there you also clearly see a loss of communication. And I think that also makes sense intuitively. If cells and synapses are lost, then you would expect that there would be a loss of communication, and that's also what we see. And then if you look at the whole brain as a communication network, a more recent insight, I think this is, has become clear now over the past decade maybe, is that I think it's kind of a fascinating finding, is that especially the well-connected or highly connected regions, which are often called hub regions, they seem to be vulnerable because over time you see that especially these regions lose a lot of their connection and connectivity to the rest of the network. So that means that the network kind of loses its hierarchy or its structure a bit, and becomes less efficient and less robust to damage as well. There are a lot of markers with which you can describe this. So to move from insights about what changes in the brain in dementia and Alzheimer's disease a bit to more the clinical practice. How do we use it in clinical practice? So by now we know that in different disease conditions, different forms of dementia, different things can happen to the EEG. I just showed you what we see in Alzheimer's disease. And this slowing is not completely specific for Alzheimer's disease. You see this also in other disease conditions. For example, DLB, Lewy body dementia, the slowing in the EEG is even worse, and it's actually already in an early phase of DLB where patients can still have only mild complaints, that the EEG is already very slow and very disturbed. We usually say the EEG is worse than the patient. So if you have somebody with mild complaints and a really slow EEG, that is strongly in favor of DLB as a cause instead of Alzheimer's disease, actually. And then other causes can have more specific abnormalities. For example, Creutzfeldt-Jakob disease. It's a more rapidly progressive type of dementia. It's also more rare, but there you can see very specific changes in the EEG that can sometimes really point you to the diagnosis quite quickly. And then, of course, it can also be the case that the underlying cause for the cognitive complaints is not neurodegenerative dementia, but is something else, like, for example, a more chronic delirium. You have forms of epilepsy that can resemble dementia. For example, temporal epilepsy can be tricky because it doesn't have to give seizures with a lot of motor symptoms, but it can just give fluctuations in attention, which can be really difficult to pick up from the outside when you look at a patient, but which you can find on an EEG, and which can be treated usually with anti-epileptics. This is not a very frequent cause, but we do encounter this a few times a year. So people being suspected for dementia, and then actually we find that it's a bit of a rare form of epilepsy that you can treat. It's also good to talk a little bit about the left column, because we also know that the EEG and the MEG can be normal in people, for example, with FTD, so the frontotemporal dementia, and in nearly all of the psychiatric diseases, at least when you look at resting state data. So, for example, depression, we see a lot of people who have cognitive problems like memory decline, but also mood problems. And then you can have the clinical doubt, are we looking at a patient with starting Alzheimer's disease in reaction to that mood disorder, or is this actually somebody with a primary depression, which then also leads to some memory deficits? And that can clinically be quite difficult, but then in the EEG, in the case of Alzheimer's disease, you would expect slowing, while with depression, you would expect a normal EEG. So in that sense, EEG and MEG can help you with making that distinction. So as a diagnostic tool, we think it's a valuable tool. It's quite broad. It doesn't have the most specific markers for diseases. For example, for Alzheimer's disease, nowadays the PET imaging and the CSF, where you can really show amyloid and things like, they are considered to be much more specific. But yeah, since the EEG is relatively cost effective, it's really low burden, it can be a good, we think it can be a good good diagnostic tool in the right context. Okay, then another applied topic, of course, is using EEG and MEG in clinical trials. I will get back to that shortly, of course. And then another thing is more fundamental or basic research, trying to improve the markers that we have and also develop new techniques. And that's something I will say a bit more before we go to the EEGlab part. Yeah, here I realize this will be a bit of a boring and very busy slide with a lot of text, but I just wanted to sum up some of the types of studies that we have been doing in the previous years using MEG or related to MEG, just to show you that yeah, we as a center, we have started quite a long time ago using MEG, and that is mainly due to the presence of our head of our department, Professor K. Stam, who, well, I think we consider him as a pioneer in neurophysiology of dementia, developing a lot of new measures and new approaches to look at EEG and MEG data. And for example, a marker called the PLI, which is a marker of this connectivity between brain regions, that is now being used a lot by different groups, that was developed here and described in 2007. I think we were also a bit among the first to start using graph theoretical measures. So these are measures that say something about network activity, looking at the brain as a functional network. And yeah, so applying concepts of network theory to MEG data and to EEG data. And yeah, using this, we were able to describe new types of differences between different types of dementia. And there are a few reviews from our group as well that deal with this type of analysis and what it has learned us over the past decade, the past years, using MEG in Alzheimer's disease, for example, also. And more recently, we have started looking more at local activity, for example, hippocampal activity, which is of course a more deeper structure, but very relevant in Alzheimer's disease, because that's usually where early damage occurs. And with EEG, it's quite hard to reach hippocampal activity. So there we have the added advantage of MEG and using source reconstruction to go to deeper structures and look at the hippocampus, for example. And yeah, this is we try to develop new types of markers that might be more sensitive to very early phases of the disease, because we think or we know that brain activity changes already in a very early phase, before complaints start and also before there's a lot of amyloid deposition. So if we are able to pick up this very early change in behavior of the neurons, that could lead to very sensitive early markers, where we are not there yet, but we do see very early changes with MEG and EEG. This is work we have not published yet, but we are now looking at a twin data set of people who don't have any cognitive complaints, but of whom part they were followed up over time, and part of them did develop amyloid deposition, and there already at the baseline we can see very subtle changes in MEG activity. This is a project that hopefully will be published also soon. And finally, I just wanted to mention, thought it would be nice to show that we actually had a recent publication in a dermatology journal, which I would never have expected, but just to show that we're also looking at completely different types of disease, not just dementia, but also people with, for example, other neurological disease like MS, movement disorders, but also even outside of neurological disease like, yeah, in this case, this is about a study about urticaria, which is a dermatological condition, which apparently also seems to have an effect on brain activity. So quite diverse, I'd say, although we do have a strong focus on dementia, of course. Moving on to the EEG lab work, and this is something we started with in about 2010, because as a center, the Alzheimer Center, we were involved in a clinical trial, medication trial in Alzheimer's disease, and there people decided it would be a good idea to also see if there would be an effect on neuronal activity as an outcome measure. And yeah, from that, I think as we as an Alzheimer Center, we do have good connection with other clinical trial centers and other Alzheimer centers worldwide. More study designers became interested in the possibility of using neurophysiological outcome measures for their trials. So by now, I think we've formed and these are usually larger multi-center international studies running for several years. And for this, we offer, we act as a vendor, so we offer to advise during the setup of the study, but also during the study, we coach the sites in being able to provide good quality EEG and MEG data. We analyze this data and we report about it, but we also participate ourselves as a site in those kinds of studies. So and here I'm talking a bit again about Alzheimer's disease mainly, but I think this also applies to other diseases, other brain diseases. A lot of the compounds that are being developed as a treatment, they from fundamental studies, they know that they can have a positive effect on synapses. So for example, getting rid of the amyloid deposition and improving synaptical function. Well, then of course it's logical that means that neurons start to behave more normal again, and that's the main motivation to start to use EEG and MEG. So if you are able to, of course, in the end, what's important is that you see symptoms decrease or disappear. But as an intermediate step, if you can show that brain function normalizes, this of course also shows that that your treatment has a positive, not just a positive outcome on the function and performance, but also on the brain itself. So for trials, we again have a focus on resting state data because we think this is quite straightforward to do with people with cognitive complaints. They don't have to do specific tasks. They can just sit quietly for some time and we do a resting state recording. And as far as the analysis, we really focus, by now we know that the more traditional or basic measures like spectral power, they give the most robust and most sensitive measure to use for treatment monitoring. So it's actually the measures that we also use mainly for the diagnosis that seem to be most effective or most reliable also for treatment monitoring. And so on the left hand here you see different levels of activity. So the level 1, so the oscillatory or spectral analysis. So these are things like spectral power, peak frequency, which are very basic measures that are often looked at in EEGs and MEGs. They remain for us still the most powerful measures to use for clinical trials. On top of that, you can do more advanced analysis like the connectivity or even network analysis, and we usually do this, but this is usually more exploratory. And the primary outcome measures for EEG and MEG are usually quite traditional measures like relative power in the theta band, for example. So this is, I already talked a little bit about this. This is again the slowing in Alzheimer's disease. What we try to aim for, what you would like to achieve with a treatment, and this is also based on, here I show you some diagrams of the very old studies with choline esterase inhibitors. So this is the medication that we at the moment have to prescribe to patients in Alzheimer's disease. What they do, of course, they don't directly counter the disease, but they also improve neuronal communication. And what was shown in these older studies already is that people who responded favorably to these choline esterase inhibitors, they also showed a decrease in the slow EEG activity. So here you see on the left the very slow delta activity, and on the right also slow activity, theta activity. And well, you can see on the y-axis that the values are about 0.4. So that means that compared to people in the placebo group, which were at 1, so there was quite a clear decrease in delta and theta activity. So in other words, in people who improved cognitively or who stabilized, we also saw a decrease in these slow frequencies. So you want to get rid of this slowing. So that is also what we try to aim for, I think, with the newer types of medication, is if you are able to stabilize this slowing, or maybe even improve or reverse this slowing a bit, that seems to be the most robust sign that you're on the right track to having a beneficial function. And in addition to that, I should say that, and I will show it later also as well, improvement in connectivity. So if you are able to improve the communication between brain regions, that would of course also be an improvement that does not happen spontaneously, but should be seen as a drug effect. So if you are able to make connectivity stronger between regions, as described by the different markers that we use, yeah, that can be convincing effect as well. I will give a few examples of that shortly. Just to say a bit about the practical setup, this is a bit of like a run through that we go through when we start with clinical trials. So usually we are involved in very early stage in the study design. So of course people will have wonder, like, how often should I make an EEG? Of course at baseline and maybe at the end of the intervention, but maybe also time points in between. What kind of EEG? What kind of specific technical settings would you like in the EEG? So these are things that we advise on, and then a study protocol is developed. And there we usually also take care that we have a site manual, which is for the sites that are participating in the study. We'll have all the instructions there on how to perform their EEG recording and how to deal with the data. And yeah, we also have a bit of a quality check in place there, which is called the dummy run procedure, where before we start with the study, we want to know if sites are able to provide good quality EEG data. So they do have to get kind of a quality approval from us. So we ask them to upload some sample data according to our specific technical requirements. And then if they're able to produce good quality EEGs that we can use for our analysis, then they can also move on to participate in the EEG part of the study. So we can take care of the data management and also yeah, instruction before and during the study for the sites. And then yeah, during the study, what we mainly work on is then the EEG data is coming in, of course. So sites record their EEGs, they upload this to an online portal, and from there we can take it, and then we aim to have a quick quality check, because we want to know quickly after recording if an EEG quality is good enough. Because if somehow there are technical problems or large artifacts, we want to be able to say, okay, this EEG is below standard, and see if we can record it again. Fortunately, that's not necessary often, but yeah, you want to have as much as good quality EEG material, of course. So this is our way to during the study make sure that we have good quality data. And then at the end of the study, of course, we can evaluate the full data set, do all the quantitative calculations for the different measures, and then usually we hand this over to a statistical analysis team for the final unblinded statistical analysis. And then, of course, we can help in drafting and presenting the results. So yeah, these are a few slides. I will go over quickly because I see we're already running. The time is going fast. These are just some examples of these come from an e-learning that we provide for sites when they participate in the trial to instruct them. Besides our EEG site manual, and yeah, it's just to instruct people on how to perform the EEG. But yeah, usually if we work with experienced centers or clinics, they already know, of course, how to perform an EEG. But we do have a few specific points that we like to point out. And I think one thing that I would like to mention, and that we cannot stress enough for dementia research, is the danger of drowsiness of the participants. Because I think it's true for everyone. If you sit quietly in a dimly lit room and you have to keep your eyes closed, it can be hard to stay awake. And then the problem is that if you start to get drowsy, there's also slowing in your EEG. And this can resemble the slowing that you see in dementia. So then you could, of course, misinterpret your data and think that that it's actually pathological, while actually somebody's getting really drowsy. Unfortunately, EEG technicians, they know how to recognize this and how to deal with this. So yeah, fortunately, we can definitely work around this. Yeah, I want to show you a few results of previous trials, just as an indication of what you can see. I have two different results. This is from a trial called the Sapphire study in 2018. It was reported. This is anti-amyloid treatment, so it's a compound that actually is aimed at one of the forms of amyloids, trying to reduce the toxic effect of amyloid in the brain in Alzheimer's disease. And this was a 12-week study where we did EEG baseline and at the end of the study. And yeah, the diagrams here are not that clear, but what we saw was there was a consistent stabilization of the slow activity in the treated group, whereas in the placebo group, there was a gradual increase of the slowing, as you would expect in a normal disease course. So here we seem to be able, that in a 12-week period, there seemed to be a bit of a stabilization of this slow activity, which was regarded as a drug effect. Another thing we looked at, and here it's not about the details, but yeah, this was a measure. The AEC is a measure that looks at connectivity between brain regions, where we also could see that in the same study with the same compound in these 12 weeks, there was an improvement of functional connectivity. So the communication between regions. And this is a result that you don't see in the natural course, because you only see a gradual decline. So this improvement was also taken as a drug effect from this study. Follow-up studies are currently running. This was a more recent study. Again, it's quite a busy slide, but I'll try to walk you through it quickly. This was a different type of compound from Cognition Therapeutics. Compound at the moment called CT1812. This acts, tries to prevent. It's also, I could say, targeted at amyloid. It tries to prevent the binding of amyloid to receptors. And this was a very short trial, only 4 weeks, but still there we were able with EEG to show that after administration of this drug, the treated group actually showed a decrease of the theta, of the slow theta power, and also an improvement again of this AEC measure, so of the connectivity. So really similar improvements that we saw in this larger trial I just mentioned, only in a time span of 4 weeks. So this was quite interesting, we thought, and there's also a follow-up trial from this study underway. I also want to, of course, put in an example of an MEG trial. So this was a bit older already, and we had first there was an EEG trial on Suvenate, which is actually a nutritional supplement, which seemed to have beneficial effects on the synapses. So the idea was, if you improve your synapses, that might be beneficial for AD patients. And the initial EEG trial was positive, and then there was a follow-up trial with MEG to look more in depth into these results. There, unfortunately, the primary outcome measures were not positive, so no clear improvement there. but this is a trial where we did use MEG. And I think, yeah, MEG was used here is of course, you can do more advanced things with the MEG, but I think mainly like the most important measures were the same as in EEG. As I said before, they're relatively traditional measures like spectral power and peak frequency. So, of course, we would like to, we're always looking to promote the spectacular capabilities of MEG. And of course, it would be really nice to see an increase of the use of MEG in clinical trials in dementia. Yeah, I think what is yeah, because what might be slowing that transition down a bit, of course, that MEG is very capable, but it is a much more expensive type of equipment, and it's less mobile. So, for example, in the Netherlands, we have one available, and then the other one is in Nijmegen, and there it's mainly used for research purposes, so a bit less for clinical care and clinical trials. So just point out that it's not available everywhere, like the EEG is available in nearly every hospital. And then more on the theoretical side, if you look at the measures that are used, it's mainly the traditional measures, so the spectral power, which you can do with EEG just as well as with MEG, that are useful for trials at the moment, we think. So yeah, we still have, I think, they have to find better markers in MEG that are based on the technical superiority of MEG. For example, looking at deeper regions or more advanced type of measures that they still have to prove their yeah, superiority over the traditional measures. I think for the MEG to become even more attractive for clinical trials. So I realized that we're already quite late in time. Maybe I'll keep the new development part a bit short. Yeah, I just wanted to say a few things about two developments that we focus on that might be also interesting in connection to MEG. We have been using computational modeling a lot to simulate EEG and EEG and MEG data. And the nice thing is that with models of EEG and MEG, you can do things that you cannot do with patients. You can, of course, intervene in the model. You can apply damage to the model, or you can put some kind of virtual therapy in the model. And then these models generate EEG and MEG data that you can compare with actual patient data. So it's not a way of trying to understand the changes that happen in disease, trying to find principles, but also trying to predict an effect of pathology or an effect of therapy. So, and I'm going to just skip a little bit over these specific results, but what I want to point out is this idea is that we think that the combination of doing accurate recordings of brain activity with MEG can be part of a larger environment where you think of a specific treatment. It can be medication, it can also be brain stimulation, and you predict some kind of treatment, maybe a personalized treatment based on brain data that you have of a patient. Then you do the intervention, again, medication, or as you see here, brain stimulation. You again record brain activity, and you can compare that to the previous situation, see if you have an improvement, see if you can adjust your prediction model, and then go through this loop again and again and see if that can help to kind of accelerate and facilitate development of better treatments. We think this approach could yeah, be better than just like trial and error in patient trials, leading to relatively more patient burden. So we think that the combination of new therapies like brain stimulation and the modeling and the MEG could be a very nice combination to which is now mainly a research field, but because brain stimulation is a strongly upcoming field, I think, in Alzheimer's disease, this could find its way to real clinical trials and maybe to clinical care sooner than we think. Okay, I think I'd like to stop there. I've hoped to have shown you that, yeah, in our opinion, of course, and yeah, we have relatively broad experience now with EEG and MEG in dementia. It's a useful tool for diagnosis, and we use it a lot for research, of course, to try to improve diagnosis, maybe also prognosis and treatment. Main findings are slowing and this loss of connectivity. In trials, it is interesting because most of the interventions, the pharmacological medications, they try to do something with improving synaptical function or neuronal function, and that's something that we, I think, EEG and MEG are the most direct representation of what is happening to neurons and synapses, and they can show meaningful changes already in short time spans. So this is the people who are working here at the moment, our neurophysiology research group. And specifically would like to point out Arjan Hillebrand, who's our MEG expert here at our center, who is in charge of our current MEG system, and who is also a specialist in beamformer reconstruction. So using source-based methods to really look at deeper brain regions with MEG, and who's also actually actively involved in developing new types of MEG, for example, OPM technology MEGs. In my last slide, I gathered a few reading tips. If you find this topic interesting, then one of the things you could look at is a chapter that we wrote in a drug development book for dementia, which was came out 2 years ago by Jeffrey Cummings and other well-known Alzheimer researchers. There's one chapter in there specifically the role of EEG, but it also applies to MEG in Alzheimer's disease. And it will cover more extensively a few of the things that I talked about today. And then there's one recent study where we looked a bit more at longitudinal changes in EEG and considerations that come out of that for the design of clinical trials. So, for example, looking at sample size calculation, what measure do you use, how robust are the measures, and so on. So that could be a good relatively up-to-date source. And then I also at the bottom posted a link to one of our e-learning examples, just as an example of if a site participates in a clinical trial, yeah, they will get an instruction from us about the different specifics of the study, and you can, if you find this interesting, you can have a look around to see what the details are, like more concerning technical settings of the hardware. So that's where I really would like to stop. Realize that there's not that much time left for questions, but if there are any, I would be very happy to answer them, of course.
Thank you very much, Dr. de Haan, for your talk. It was really insightful. We've run over slightly, but there's still quite a few people online, so we've got time for some questions. Let me have a look. So the first question, have you made any correlation between repetitive brain trauma injury and Alzheimer conditions in your cohort?
Well, we have a group here that is focusing on traumatic brain injury, like a CTE, like a chronic traumatic encephalopathy, led by my colleague Jort Vijverberg, one of the other neurologists. So as far as I know, they have not yet included neurophysiological techniques like EEG and MEG. So I think now they mainly worked with other imaging modalities. So I can't really say anything about EEG or MEG in that context.
Our next question, how accurate are the findings of MEG studies for Alzheimer's disease diagnosis at the individual level, as the studies are done at the group level?
Yeah, so like I said, so the slowing that we see in Alzheimer's disease, yeah, there is some, of course, quite some individual variability. And in the early phase of Alzheimer's, the slowing can still be, yeah, not there yet or very subtle. So these measures don't seem to be like very strong or accurate early phase measure. That's why we're always looking for better measures. But yeah, what the best markers we have at the moment, their sensitivity and specificity are around 80%. So it's not terrible, but it's not as good as you would like them to be. with machine learning approaches, we have seen studies appear, and also we ourselves in our group, we have done a few machine learning studies that seem to get to a better classification. But yeah, I think the methodological choices are still, I would say that's still under development. So yeah, I don't think EEG or MEG can be used as the only marker, but what our experience is that in the right clinical context, like for example, what I talked about, when you have doubts between neurodegenerative dementia or depression with cognitive deficits, or some kind of delirium or a type of dementia where the EEG should be normal, especially in those cases, the EEG can be a relatively low cost, very effective instrument. So I wouldn't say that it's suitable for all diagnostic situations, but in the right context, it can be very, very strong.
Our next question, why do we mainly focus on resting state data and not on task or evoked potential data?
Yeah, that's a good question. It's a choice by us. I think we have a preference for resting state because the resting state data is already interesting enough. You see a lot of changes happening there. And yeah, we have the feeling that in this group of people with cognitive impairment, setting up tasks and being reliable in performing tasks can be more difficult. Also, we think the interpretation of task data can also be difficult. It can also be a bit more movement artifacts, for example. So yeah, we just have most of our experience is with resting state. But that's not to say that task data and evoked potential are not useful. It's just that it's less of yeah, it's less for our expertise. But I've seen interesting examples of course of also task related results and evoked potentials, and also sometimes companies who want to have a specific clinical intervention study, they know from their early fundamental study in animal models, for example, that they have seen interesting results with evoked potentials, for example. And then yeah, that's something that unfortunately at the moment we cannot replicate in humans, but that's something that's on our wish list.
With regard to the combination of MEG and brain stimulation, is simultaneous stimulation and measurement possible?
Yeah, that's something that I kind of skipped over, but I like talking about this. We're looking at this at the moment because yeah, it would be very interesting to have a simultaneous electrical or magnetic stimulation and also MEG measurements, so accurate measurements. But of course, the problem is you introduce an electromagnetic field with your stimulation, which can really disturb the signal. So then if you look at the data during the stimulation, what are you looking at? Are you looking at a stimulation field, or are you looking at actual brain activity that is changing, or are you looking at a combination of the two? So that is quite difficult. There's not that much literature about it yet. We're at the moment really trying to see if we can, what we can do during MEG. And I think you can use it, and of course it would be very interesting also for closed loop systems where you can have a stimulation actually real-time react to the measurements that you do. Yeah, I think it is under development. So it is possible, but there are quite some methodological dilemmas there. But yeah, we're looking into that as well, and other centers are also looking into that.
How do the researchers handle medication confounds in their subjects?
Sorry, I missed part of the sentence. How do we handle medication?
How do the researchers handle medication confounds in their subjects?
Oh, confounds. Yeah. So I presume that what is meant here is that if people already use other types of medication that could confound the findings of a study. So that is something that we include in our evaluation. So we want to know if people, what types of medication people use. In Alzheimer trials, most of the people will be on choline esterase inhibitors, and then a new drug is added on top of that. So that's something that we have to accept because we cannot deny like the standard treatment usually to people. But people can also use other medication that can interfere with the EEG or the MEG, of course, like sleeping medication or other psychoactive medication. That's something that we need to know. Some types of medication can really be a problem because they can really also give slowing or can give abnormalities in the EEG and the MEG. But at least if you know what people are using, then you can usually work around that a bit. But that's something that we routinely ask the sites to fill in for every visit. So we want to know what people have had the days before the registration actually. Yeah.
I think we've got time for one more question. In the Alzheimer field, EEG and MEG is not used a lot as diagnostic or for treatment monitoring. Why is this not more common?
Yeah, that's a good question, and something I'm asking myself a lot. I think there are multiple reasons. I think when you look at the development of the Alzheimer research field in the past decades, a lot of focus has been on imaging, like the MRI findings, and then on PET imaging and on CSF, because there you have the very strong amyloid and tau markers, very understandably. And I think, what you often see is that people make a large jump from, of course, when you think about disease, people are quite pathology based. So I think if we can get rid of the pathology, then you expect cognition to improve. So we think that's a pity because you miss out this whole territory of brain function and activity. And it could be that if you, like with brain stimulation, you intervene in this brain activity, which might be more downstream from the cause of the disease, but it could be more effective. Because if you think about the best that we have at the moment, the choline esterase inhibitors, they're not targeted against the cause of the disease, but they support brain communication. So it could be that brain stimulation, although not curing the disease, might actually be more effective in maintaining some level of cognitive performance. So both for treatment and for diagnosis, I think for diagnosis, I think also a lot of people, dementia patients are often seen by neurologists, but also of course by, depends on the country a bit, but by psychiatrists or by geriatricians. And though they usually don't have much familiarity with EEG and MEG. Even neurologists, which are closer to it, they often find EEG and MEG relatively technical types of technical techniques. And I think that is true, but the performance or the performing an EEG is relatively straightforward if you have an experienced technician and you know what to look for. As I've shown you, I think the type of analysis that you do is quite straightforward. We don't need to use very fancy techniques. It's just a resting measurement, looking at very basic measures. So I think it could be used much more. And that's also something that we are actively working on to see if we could, at least in the Netherlands, you have to start somewhere to see if the EEG could be a more active part of guidelines. Because I think also given in the right setting, EEG can have good diagnostic properties, diagnostic qualities. So in short, the different reasons why it's not used as much as it could be.
So I think that's the end of our Q&A section. We've answered all the questions. Thank you, Dr. de Haan, for your time today and for this excellent masterclass session. To all of our attendees, thank you for joining us, and we hope to see you again soon.
Thank you.
Thank you.